I'm Roger Baker, Executive Director of the Stratfor Center for Applied Geopolitics at RANE, a global center of excellence for geopolitical intelligence and analysis. Learn how you can put geopolitics to work for your organization at ranenetwork.com.
I still think the most remarkable demonstration of the effect of masks was a little video released in the New England Journal on which they used laser lights to pick up droplets. And they had a person talk and softly and intermediate and loud and showed these multiple little droplets lit up on the laser light. Then they put a mask on and they could find no droplets by laser light, no matter how loud they yelled. That proves that masks work.
Fred and Bill, once again, thank you for sharing your valuable time with us. In the intervening 3 weeks since we last spoke, new data about infection rates and also a number of new studies, the Cochrane report, just looking at the data and the science around mask wearing. Other things are coming up about the efficacy of vaccines and things like that. So it's great to have you. Hopefully we can sort some things out, and people, as always, can use your guidance. Anyway, Bill, do you want to start with a quick update and broadly in terms of what's happening around the world, and Fred, just in terms of what you're seeing and through your network?
David, the last time we talked, we were just at the end of Lunar New Year. And what we were saying was that we were not seeing any significant surge. Many people were afraid that the Lunar New Year, with being the numerically largest travel period of the year worldwide, was going to intermix various strains of SARS-CoV-2 around the world and create a new surge. Well, that didn't happen in most of the world. There were a couple of exceptions, and I'll talk about them. But we're now we're roughly a month out from Lunar New Year, and I know we have not seen a surge, and so I think we're safe to finally say that we're far enough past it that we dodged the bullet on that. Well, retrospectively, looking at the graphs of data regarding the three main parameters of cases, hospitalizations, and deaths, there was a small blip. I mean, it went up just a few percentage points. You can see it when you look at a graph, but it was very minimal, not impactful at all. And in fact, hospitalizations and deaths have, since the beginning of February, have started to come down. And now, if you look at the CDC's United States map, you'll see that almost the entire country is green. There are certainly isolated counties, as well as eastern Pennsylvania and western New York, much of Maine, that are still in the yellow moderate impact region. But those are mostly not due to the numbers of cases and deaths, but due to the underlying hospital capacity in those areas. And hospital capacity is being used for other things also. So while I hesitate to say that we are completely done with COVID, I do feel very comfortable saying now that we are in a very good place. And I think it is reasonable for most people to look at COVID the same way that they look at flu during the typical flu season. Something you want to pay attention to, be careful about, but you're not going to change your life and your lifestyle because of it.
David, I agree with Bill. And there in where I live in northern Florida, we do have a pocket of moderate activity, and we're seeing some hospitalizations, but most of them are hospitalized with COVID. In other words, they're hospitalized for something else, and when we do the PCR, RT-PCR, it's positive, but they don't have much in the way of symptoms. There's no question that the Omicron variants are milder and do not cause patients to be hospitalized as often. And it is a milder disease, and fortunately, a high percentage of the population at least has the original vaccine. This last booster, only about 16% have gotten that, but it turns out that may be icing on the cake to some degree, and I think I agree we're out of the woods overall.
And David, in fact, I'd say at this point that what I am watching right now, even more than I'm still keeping an eye on COVID, but what I'm watching more carefully is influenza H5N1, avian influenza. Avian influenza has made a jump from birds to mammals in several areas of the world, and there have been at least 2 known cases of bird to human jump of H5N1. Both of those happened in Cambodia. Beyond those 2 cases, there's no evidence of a jump to humans, so it's not something that's scaring me immensely at this point, but it is something, just like COVID, that I'm keeping an eye on, because if it did make that jump, H5N1 is not protected effectively by the current vaccines, and we would need to be careful about how we handle it.
Fred, do you have any thoughts on basically the threats of influenza?
Well, yes, we always have to worry about influenza, and the avian influenza it can be quite virulent, and we don't have the same immunity to it, so it is a potential risk. So I think it's probably won't have, even if we were to get full blown, would have the mortality rates of COVID-19, but it's something to definitely be concerned about. And we'll just have to keep our eye out. One other point, I remember Bill and I were very worried about China creating new variants for the COVID-19. And it turns out there have not been, to my knowledge, any new variants of interest or mutants of interest. And it does seem that the new and more aggressive as far as spread variants have not arisen. So that is really good news.
David, the other thing I think is worthwhile talking about that has caught a lot of people's attention over the last week to 10 days was a study that came out from the UK, from the Cochrane Library, which is a highly respected organization that what they do is they put together other studies. In this case, it was, I believe, over 70 studies that they looked at and came to a bottom line conclusion that you cannot draw any conclusion that mask programs made a major impact on stopping the spread of COVID. Now, having said that, you have to parse words on this one, and different people are parsing the words they want to. On the unfortunately, it's come down to a right-left viewpoint on this, but the right side is saying that this means that masks were worthless and mask programs did more harm than good. On the left side, they say, wait a minute, this did not say that masks are not effective. This said that mask programs are not effective. So in reality, I think as I've read through this whole thing, I think it's both are true. Mask programs were not demonstrated to be very effective, but masking themselves, if somebody wears a mask, wears it religiously, and it's a high quality mask and knows how to wear it correctly and is not mussing and fussing with the mask and infecting themselves in other ways, which is also a problem when you wear masks, then masks can be effective at the individual level. They are not, however, effective at the program level, where most people, as we've all seen, people wearing masks over their mouth and not covering their nose, they're not effective at that level. But the other place where they can make a difference is they keep people who have COVID from spreading it easily. So they're effective in that way. So it really is, when you look at this whole Cochrane Library study, you can take what you want out of it. But the big thing is, to me, is that it's the mask programs are not effective. But if you want to protect yourself, masking for yourself can be useful.
So, Bill, I'm glad you brought this up, and Fred, I want to get your perspective, because from the very beginning of our podcast 2 years ago, we talked about the politics around the pandemic, and obviously information, disinformation, the science, the data. And the Cochrane Library, Bill, Fred, you'll correct me if I'm wrong, but I've read enough about the work that they do, is viewed as a highly regarded, if not the gold standard of medical research, curation, and publishing. It is relied upon throughout. And the point, Bill, that I hear you making, and I just, I want to underscore it, is that because politically, in a wide variety of media sources, and you're seeing this report cited as definitive proof that the mask mandate was ineffective, and that the notion that masks could protect people, and that includes masking children in school, etc., was otherwise ineffective. Otherwise, it was misguided policy, otherwise was misguided science. And what I'm hearing you, Bill, but also other experts that I've been able to speak with, is this notion that when it was decided to roll out a broad mask mandate, it was a good, I'll call it a good faith effort. But what the data has shown is that masks are effective. You see, if they weren't effective, you wouldn't see doctors wearing them all the time, and that's sort of my takeaway. But the point here is that on an individual basis, when masks are worn properly, when high quality masks are deployed, when there is general adherence to wearing them in public and when exposed to people and things like that, they are effective. It's just that as this program was rolled out, it was not as effective, but for reasons that had nothing to do with the science of masks and mask efficacy, but really had to do with how masks were deployed. Is that a fair summary?
David, yeah, I agree. I work in the field of quality and safety, and this requires that physicians and nurses change their behavior in order to reduce risk to patients and improve the quality of care for patients. Well, we know, the science tells us that if we mandate that somebody do something new, you get a 5% change in behavior. So mandates are well known to be resisted and are not effective. So the fact that you mandate it means absolutely nothing. That does not mean that masks are not effective. That means that people won't wear the mask if you mandate them. In fact, they may resist further, and that's exactly what happened. And the Cochrane report proves that. Now, we actually, what we've had to do when we insert a new protocol that we know will make a positive impact on patients, we have to monitor the behavior of those that are supposed to change their behavior. We know now that it takes 70% of those faithfully following the protocol to see an effect on patient safety. So if you only have 20% or 30% that are doing it, and that's probably pretty much what was going on in most schools, probably only 30% of the kids really followed it faithfully. Another 30 sort of did it, and then probably 30% didn't do it at all, or very, very little. So, of course it doesn't work. That doesn't mean masks aren't effective. It means that people don't want to wear them.
David, I think, unfortunately, you can, not to get too political here, but you can generalize this whole concept that when people say follow the science, yes, you can follow the strict science, but you've also got to take in the behavioral science aspects of things, and you've got to take in second and third order effects when you make policy decisions. That's as far down the line on politics as I'll go on this.
We've protected both of you for 2.5 years, and so I'm not about to leave you exposed.
One other thing I would say, I still think the most a remarkable demonstration of the effect of masks was a little video released in the New England Journal on which they used laser lights to pick up droplets. And they had a person talk and softly and intermediate and loud and showed these multiple little droplets lit up on the laser light. Then they put a mask on and they could find no droplets by laser light, no matter how loud they yelled. That proves that masks work. So come on, why wouldn't they work? I mean, it doesn't make any sense. I can understand you not wanting to wear them. That's a different story. And if you don't wear them, they're not effective.
Right. And to me, and Bill and Fred, I'm sure you have been through the report more carefully. To me, the question of the efficacy of mask wearing would have been a better question if they had analyzed it amongst hospital professionals and nurses, doctors, who were wearing the right kinds of masks and wearing them in the right kind of way, whether that was effective. And the reason I have no dog in the political fight here, but if masks were not effective, I would have a hard time understanding why for decades and decades, generations for that matter, doctors and nurses and hospital professionals have masked up for surgery, masked up for ICU units, pediatric units, etc. So maybe you can just expand upon this a little bit.
Yes, David, that's actually an incredibly important point. The reason that medical professionals wear masks on a general basis in any of those high-risk environments is not to protect the mask wearer. It's to protect the environment, the people in the environment, from someone who may be sick and doesn't realize it. That's why with something like COVID, which had, especially initially, not so much now, but the early COVID had a long asymptomatic yet infectious period. In that environment, a mask mandate where you make people wear masks even if they're not feeling sick has some merit. But in an environment where people are not very infectious until they show symptoms, masks have less efficacy, actually, as long as people put on a mask when they do feel symptoms. But the reason for wearing a mask in a hospital is not to protect the wearer, it's to protect the other people in the environment from the wearer.
And public policy being predicated on if we could get enough people in public to wear masks in the right kinds and the right ways, that we could not obviously obviate the spread of the pandemic, but we could mitigate. And that's what I took away. Fred, you may have some additional thoughts.
That's a very good point, David. The masks are not foolproof, and there can be some leakage. Some particles can get out, some aerosol can get out, no matter for any mask. However, the number of particles and the dose of the virus that would spread would be markedly reduced. And we know that if someone gets a lower dose of the virus, they're likely to get milder illness than if they were to get a heavy dose and someone who is not wearing a mask that coughs in somebody's face. And that does happen, and that is where we got into real problem prior to vaccination. And there were a number of cases. I know in our own city, there was a bus driver and a woman sat behind him and coughed on him, and a week later he was dead. So there was definitely a dose relation to this. And if you wear a mask, you're going to reduce the dose that you give to somebody else.
David, I wish if we could have one big change, it wouldn't be that for us to have mask programs when we have infectious respiratory diseases, but we have a cultural change that if you have a cold, or flu or something like that, you either stay home, which is the ideal, or if you are out in public because maybe you feel like you're not that sick, in that setting, you wear a mask. In Asia, I've spent a lot of time working in Asia. In Asia, it is considered it's almost dirty if you have cold symptoms with runny nose, cough, and you're out in public without a mask, people look at you like, I'm not going to try to draw any parallels, but they look at you like you're dirty.
Yeah, so I'm glad you brought this up, Bill. I have a number of friends who are of Japanese descent living here in the States, people who are still living in Japan, expats, etc. They never quite understood the political uproar around mask wearing. It is the height of, I'll call it inconsideration and disrespect for your colleagues and friends not to don a mask when you have some form of illness. And so I don't want to say they looked at it with bemusement, but something that is absolutely accepted and people don't give it a second thought. So let me move on, because there's a very good question, and in light of the data around COVID, people are looking at their vaccination cards and they're coming up on 6 or 7 or 8 months since their last booster. I'm not going to ask you what should people do. I'm going to ask both of you, what are you doing in terms of considering any kind of booster, and not just for yourself, but for your family members. I know each of you are responsible for people of a wide variety of ages. So that question has come up from our network, our audience. I wanted to basically get your views on that.
Well, as you know, 2 weeks ago, I guess 10 days ago, the CDC changed the vaccine advisory tables across the board to include COVID vaccine as part of the standard usual childhood vaccines and as recommended vaccines for adults. That has caused a lot of controversy. I think it was actually an unforced error on the CDC part, because by including that in there as a standard recommendation, it's inviting controversy, since the data is still somewhat equivocal on the issue. Just today, as a matter of fact, the CDC came back and they added to the recommendation, kind of backed off a little bit and said there is not enough data as a minimum, there is not enough data to support multiple annual boosters. That right now, what they think is best for adults is to have adults with risk factors, including age, is to have a single booster, most likely in the fall, but not multiple boosters over the course of the year. And they were silent on whether adults in general, the same target population as flu vaccines, they were silent as to whether or not there's a recommendation for that. So there's a little dichotomy coming out of two parts of CDC on whether people should get COVID vaccines ad infinitum or not.
Well, Bill, I'm not going to let you off the hook. What are you doing, and what are you telling your family members, including, I know you have grandchildren that you're responsible for.
I'm not advising my grandkids to get vaccinated. I know at least half of them have had COVID. The other half I think have had COVID because they got sick about the same time the ones that we know did. For young adults, most young adults have had COVID, or at least they had their basic vaccine. I think that's, at this point, I don't think there's any indication for additional vaccines. My father is over 90, and I am getting him a vaccine whenever there's a booster, because I don't think someone at the old age is effectively making antibodies as well. So reminding their immune system that it's there, I believe, is a good thing. And then taking into people who have immune deficiencies are in the same category as my father. And then that leaves kind of if you want to say the 60 to 75, 80-year-old population of healthy older adults, should they get a vaccine or not. I think the annual vaccine, I got a vaccine in the fall. I will probably get another vaccine next fall alongside my flu shot. But I've got another 6 months to look at the data to make a final decision.
Fred, how about you?
I agree with Bill. That's exactly right. I've had more. I've had actually a total of two standard boosters and one bivalent. So I've very boosted. I'm going to wait until the fall for myself. And I agree with Bill that I think everybody, one way or another, has now been immunized. And so only those that are immune compromised in some way warrant continued vaccination, in my view, at this point.
An anecdotal report from New York City. I have more colleagues and friends who, in the last 3 to 4 weeks, have come down with COVID, oftentimes for a second time. And obviously it is disheartening to them. They talk about the fatigue, a bit of fever, but overall, because all of them have been fully vaccinated and boosted, they describe their symptoms as inconvenient and unpleasant, but obviously not, putting them at any significant risk. Nor are they taking any, medications for it other than, the standard. So, Fred and Bill, for what it's worth, a bit of anecdotal evidence about the efficacy of vaccines, but nonetheless, the variants are around, particularly here in New York. And by the way, none of these people spent any time with each other, so it's not like there was a spreader event.
One other key point is we have Paxlovid. And so if someone in the higher risk group is positive within the first 5 days, if they get Paxlovid, that dramatically reduces the risk of hospitalization. So I think we keep that in mind. That is our second fail-safe and very important.
Speaking of anecdotal reports, in my own practice, but then in many other physician practices, we've been seeing a lot of gastrointestinal disease, which many people are assuming, and there's some tests to support it, is norovirus. Primarily in the Northeast, but there's been some on the West Coast also. Sudden onset typically lasts 12 to 24 hours and is gone. CDC heard enough of these anecdotal reports that they came out last week with a statement that no, when you look at the actual data they're seeing, and they have a surveillance network for this, that this is typical for this time of year prior to COVID, that it dropped almost nothing. So it's what we're seeing is probably normal, but it just feels like more because we haven't seen it for the last few years.
Well, on that cheery note of what, and by the way, also have colleagues who incurred this and went through their house with young kids and everything else.
Exactly.
A very unpleasant 24 hours, Bill, as you probably know. Yeah. So I want to thank both of you for a very calm conversation and helping us parse through the noise around some of the reports and the what I'll refer to as what the data and the science is showing in a highly politicized and polarized world. So, Fred, Bill, thank you again. Look forward to catching up in 3 weeks. Stay safe.
Thank you.
Thank you, David.
And again, you have our gratitude.
Dr. Fred Southwick is an infectious disease specialist at the University of Florida's College of Medicine. Dr. Bill Lang is an expert in public health responses to biological incidents. Our host, David Lawrence, is the founder of RANE, a risk intelligence company that provides access to critical insights, analysis, and support to ensure business continuity and resiliency for our members. Learn more about RANE's market-leading risk intelligence products at ranenetwork.com. That's RANE Network, RANE network.com. Thank you for listening.